Hey everybody, welcome back for our next chapter. It will be pharmacology. And so we're starting it now. It's 3 chapters that will be on our exam, 11, 12, and 13. I just sent an email out about it. Yep, here we go. So let's get started. First chapter is not that bad at all. A lot of terminology, but not a lot of theory. Let me get myself out of the way here. Let's see. And we can get started. Hope everybody's doing well. All right. So let me introduce this chapter to you. AEMTs are responsible for the administration of certain medications to ill and injured patients. Some of these medications administered incorrectly, they can produce problems, life-threatening consequences. So medication errors are a big deal. So when we're talking about medications, remember your 5 rights. But you must have a good understanding of pharmacology. Pharmacology, the study of the term, I guess, for pharmacology, the study of origin, nature, properties, action of drugs, and their effects on living organisms. So there's 4 basic sources of medications. Those sources are plant, animal, mineral, and synthetic. And the think about it thing here, discovered in 1921, insulin has saved the lives of 15 million people with diabetes. And insulin is mainly derived from the pancreas of pigs and cows. Interesting. Medication reference material. So the PDR. That's really the physician desk reference is going to be your number one. I mean, most of the time that's your number one pick to look up a drug, to get educated about a drug. There's others to be familiar with, the American Medical Association and the hospital formulary. All of those are good. So medication profiles, what do they consist of? Well, a medication name, it should have a classification, a mechanism of action, indications, pharmacokinetics, side effects, route of administrations, how we're going to give it, right? The contradictions, and some of these drugs have contradictions at certain situations that you can never give it. But then there's relative contraindications, right? Take for instance, we'll use like a clot buster drug, TKA or TPA, something like that. Well, like a history of a GI bleed is a contraindication to that drug, right? Well, if they haven't had a GI bleed in the last 15 years, right, and they're not actively bleeding, sometimes the risk may over the consequences of what's happening to the patient may be worse than the risk. So relative contraindications here are important too. The dose, how is it supplied? And are there any special considerations for the drug? Medications and medication name. So, and under the name, we have 3 names for the medication. We have a generic name, a trade name, and a chemical name. When we look in the classification, what type of medication is it? There's different classification schemes that are used, mechanisms of action, and what part of the body system does this drug work in? The mechanism of action is the way the medication achieves its intended effects. Indications for the drug. So nitro, it's clearly indicated for someone with cardiac-related chest pain, right? So that's the indication for using that drug. Pharmacokinetics, how is the drug absorbed, distributed to the tissues, and how is it eliminated from the body, right? So you have nitroglycerin. It's absorbed sublingually. It's distributed to the oral tissues there, and it's eliminated by the body in about 4 minutes. Side effects. Unintended effects of the medication. So we can look at nitro again. We know one of the side effects of nitro is a headache. The routes of administration. Can we give this drug, and some drugs like nitro, we're going to give sublingual. Right, but nitro also, it can be given different routes. We could give it sublingually. We could give it intradermally on the skin. We can give it IV. It just depends, right? It depends on your scope of practice, what you're allowed to do. But what are the different ways this drug can be administered? Contraindications. What makes the administration of this drug harmful, even though otherwise indicated for the medical problem? Right, so we could say, nitro we know is for cardiac related chest pain, but we also know it's contraindicated in patients that are hypersensitive to the drug, or if you're taking sexual enhancement drugs, you can't give it. But if I'm not taking that, then you can give it, right? That's what makes it a contraindication. The dose, the amount and frequency of the medication to be administered, right? So we know nitro in one tablet is 0.4 milligrams, all right? And we know that we can give one tablet sublingually, and we can do and repeat that dose in 3 to 4 minutes, right? So that's the dose. How is it supplied, right? So nitro is supplied in a tablet in a glass container. It's also packaged as transdermal. It's in a little packet that's like a gel that you squeeze on the skin. It's also packaged in glass bottles to be administered IV. So it has different ways that it's packaged, and its concentrations are different, right? So we know that the one we're familiar with, the concentration is 0.4 milligrams of the drug in one tablet. What are the special considerations? Special precautions to be observed when administering drugs to special patient populations, right? Some of these drugs that we have, like we'll use morphine, for instance, the adult dose, 2 to 4 milligrams. 4 milligrams might be a lot for a patient who's 80 years old, right? So we need to worry a little bit about that in the elderly patients. 4 milligrams might be a lot for that 2-year-old, right? So in those special age population groups, we have to be familiar with that. Legislation. Some of these drugs are protected from the public. They could be considered unsafe and mislabeled, right? So legislation protects the public from that. All drugs over the counter are required to have a label. They're required to give the concentration of the drug. They're required to give the dosage of the drug. What to do if you take too much of the drug. The Pure Food and Drug Act of 1906 enacted to ensure proper medication labeling. The Harrison Narcotic Act of 1914, right? Regulations on importation, manufacture, sale, and use of medication. The Food and Drug Cosmetic Act of 1938, I know everybody's familiar with. Just kidding. I'm sure nobody is, including myself, but provides additional protection to the public. It was revised in 1952 and 1962, and it provided for the formation of the FDA. Aren't you glad? Mandated prescriptions required for addictive or harmful medications. So that's your Lortabs, that's your hydrocodone, and other narcotics. They required labeling of medications that include addictive drugs and the potential for side effects. So yeah, some of the drugs that are habit forming, nicotine, got to have a label on it to tell you that it's habit forming. The Durham-Humphrey amendments were added in 1938 and again in 1951 that require pharmacists to dispense certain medications only by prescriptions. Yeah, so back in the day, you could go to the pharmacist and you could say, hey, I have a cough. Can I get the good stuff? And they would have some codeine cough syrup back there. And they would say, yeah, we got some mixed up, right? And we'll sell it to you. And it wasn't sold by like over the counter. It wasn't like it didn't have a label. It didn't have anything. The pharmacist mixed it up. Well, they stopped that. They can only dispense certain medications and only by prescription. And also it defined that over-the-counter medications. The Comprehensive Drug Abuse Prevention and Control Act of 1970, also known as the Controlled Substance Act. This replaced the Harrison Narcotic Act of 1914, just wasn't strong enough. So it made it stronger. It included the scheduled drugs, right? So a Schedule 1 drug has the highest potential, while Schedule 4 drugs, these drugs have the least potential. And so we can look at those right here, like a Schedule 1 drug up here, heroin, LSD, mescaline, and methaqualone, or quaaludes maybe. Anyway, that's your Schedule 1. So those are like super addictive drugs. They're like, no, we don't need those out there unless it's for a medical reason. And, we can tone heroin down a little bit. We can give morphine instead of straight heroin. Or you get a bunch of fiends out there wanting the good stuff. Schedule 2 drugs. Here you go. You got your morphine. You got your codeine. You got your mepridine, hydrocodone, and a host of very addictive stimulants and depressants. And yeah, we know that they are. We see pain seekers all the time. They want this stuff. The medications, all these medications up here, they require a written prescription and are restricted from you can't call it in, right? Hey, this is Dr. So-and-so here, only call in a prescription. You can't call it in from the hospital. They have to actually have the script. And abuse may result in severe physical or psychological dependence, and it does. It really changes a person when they get addicted to these things. Here's your Schedule 3 drugs. These are Schedule 3s are medications that have less abuse potential than obviously Schedule 2 do. And they have an accepted medical use, like anabolic steroids. Non-prescription painkillers combined with small amount of Schedule 2 drugs, like you have your, this is Tylenol here, active, you know what I'm saying. Tylenol with codeine, or hydrocodone, right? Your Percocet. It can be aspirin and codeine. So these drugs are mixed with a over-the-counter type drug to have less abuse potential. These Schedule 4 drugs have the less abuse potential than the Schedule 3. And these are like your muscle relaxers, your benzodiazepines, your barbiturates, your steroids and stimulants. I didn't know steroids were even a schedule. I guess some of them are maybe. But anyway. And then let's look at your Schedule 5 drugs. These are over-the-counter medications used for cough and anti-diarrhea medications. So yeah, don't do that. But a lot of your Imodiums. Did you know Imodium has a small amount of what is it? It has a small amount of a narcotic in there. But if you drank a lot of Imodium, you would actually get high. I'm not recommending that to anybody. A bowel obstruction is going to be much worse for you than your high. But yeah, that's why we have Schedule 5. We don't ever talk about them too much. All right, the FDA is responsible for testing these medications. That's their job. They want to make sure that if drugs are out there, that they're safe for the public. And so they have different testing phases, and it goes 1 through 4. So they have special considerations. We have to look at how does these medications affect pregnancy, right? Is there going to be a risk to the fetus and ped patients? Is there a physical difference between an adult and child and how these drugs react? Differences on how the medications affect the children. What's the pediatric drug dose? And it's always all pediatric drug, any dose of medication, it's always weight-based. So it could be like you take a drug X, it's going to be 4 milligrams per kilogram of body weight. Then you have your geriatric patients. Because their absorption and how they get rid of medication along with their metabolism is completely different than that of an adult patient. So all of that has to be considered. Multiple medical conditions requiring medications in your geriatric patients. We know that they take 14 different medications for 23 different problems, but does one of those medications they're taking react with another medication? And they usually have multiple doctors. So they're all out there slinging drugs, writing prescriptions. How are these drugs going to affect taking them together? Something to think about. And that's why you want to go to a single pharmacist so they can keep your records and catch these things before it becomes a problem. Back to the names. Trade name here is Provenal. The chemical name is tetrabutylamino methyl 4-hydroxy hydroxy M-xylene disulfate salt. Yeah, I like Provenal better. The generic name, we call it albuterol sulfate. And its official name is albuterol sulfate, USP. So I know a lot of times you'll see test questions, right? And it'll say, what is the official name of this drug? Pick it. Look for the USP. It doesn't matter if you know it, find USP. And then you know, well, that's got to be it. Medication forms. Forms many times dictate administration routes, right? So we have tablets, capsules, and powders. And so how are we going to give this? Kind of depends on the form. We have liquid medication, so suspensions, the tinctures, spirits, elixirs, syrups, and emulsions. So all of those are considered inside your liquid medication forms. Semi-solid medications, lotions, creams, ointments, gels, medicated adhesive patches, right? Like your pain patches or your nicotine patches, gases. So oxygen is a gas, so it's nitrous oxide. Many drugs appropriate for topical administration in adults are not appropriate for pediatric administration. That's something to think about. Medications that can affect the nervous system, right? So we have sympathetic nervous system, right? Your fight or flight. And so we call those sympathomimetics and adrenic agonists. And then you have those that affect the parasympathetic nervous system. Remember, the parasympathetic, its job is to slow down the nervous system. So, for instance, atropine. Atropine is a parasympathetic blocker. So if we have somebody who has a pulse rate of in the 30s and a blood pressure that's tanked, and we want to affect blood pressure, remember cardiac output is blood pressure, and the formula is heart rate times stroke volume. All I have to do to get blood pressure up is to affect heart rate or to affect stroke volume. So in this patient's blood pressure is tanked because they have a pulse of 30. And I go, okay, well, I want to affect blood pressure, so I'm going to pick heart rate. I'm going to pick heart rate. In order to bring blood pressure up, heart rate needs to come up. I have a drug. It's called atropine. Again, it's a parasympathetic blocker. It blocks off the part of the nervous system that slows the nervous system down. So I give this atropine, and guess what? Heart rate comes up. And so if heart rate's coming up, I'll recheck the blood pressure, and guess what? Blood pressure comes up. So that's how some of these drugs affect the actual nervous system. Epinephrine. Epinephrine affects the nervous system as well. We'll talk about it here in just a second. All right. We have alpha 1 and alpha 2, right? And we're talking about how we're going to affect the sympathetic nervous system right now. The adrenal receptors, right? And so we have A1, A2, B1, B2. We learned about it in EMT school. Alpha 1 affects vasoconstriction, right? So here's where you're going to give epinephrine, and it's going to cause those vessels to constrict, and that's going to allow for what? For more blood to get to the right side of the heart to, hopefully get there and quicker, hopefully, and increase blood pressure. A2, we don't really worry about too much, y'all. It's a peripheral vasodilation, little or no bronchoconstriction. So A2 is usually not a problem. Beta 1. Beta 1. And so hopefully you learn this, how to remember beta 1 between beta 2. Beta 1, how many hearts do you have? You have one heart. How many lungs do you have? 2 lungs, beta 2. Beta 1 is going to affect the heart. Remember, if I want blood pressure to come up, let's increase the heart rate. I want blood pressure to come up, let's increase automaticity. If I want blood pressure up, increase myocardial contractility. Remember, I just gave the example a minute ago, heart rate times stroke volume. Well, this is going to affect stroke volume, increasing the contractility. Increase conductivity. All right. Then we have beta 2. So that we're going to switch to where? The lungs. The lungs where we have bronchial dilation and vasodilation. So that should work. That should work. Hopefully everybody gets that. You're a smart group. I'm sure you do. All right. Let's keep going. Analgesics. Medications that reduce pain. Opioid agonists, non-steroidal anti-inflammatory drugs, or NSAIDs. Then we have anti-anxiety and sedative hypnotic drugs. These are designed to reduce anxiety with barbiturates, benzos, non-barbiturates, hypnotics, all in that. Stimulants. All right, so stimulants stimulate the central nervous system. So caffeine, cocaine, amphetamines, all of those affect this stimulus. Depressants. It's going to slow the CNS, right? It's definitely not going to block the parasympathetic, is it? It's going to increase it. Treat anxiety, muscle tension, stress, pain, and insomnia. Anticonvulsants. All right, these are the ones that stop seizures. All right. Psychotherapeutic. These treat mental illness such as depression, psychotic disorders, anxiety. Respiratory. These are your beta 2 agonists, right? Remember, 1 heart, 2 lungs. These are your albuterol inhalers, your corticosteroids. What about, we got cardiovascular. Cardiovascular affecting the rhythm of the heart. right? We want a nice, controllable rhythm. We don't want one that's chaotic. Antihypertensive medications, antiplatelet and coagulants, and fibrinolytics, all of those. Your diabetic patients to control blood sugar, immunosuppressants that inhibit the actions of the immune system. They're designed to decrease the body's attack on its own tissues. Some people's immune system goes ham. So that's what we're trying to do, trying to get it to stop going ham. Just like for you get a kidney transplant. Well, a lot of patients are going to take these immunosuppressants. They're packaged to accommodate the intended use. Protects medications. The packaging protects medications during storage. Some of these come as a pre-filled syringe. Some of these come in vials, ampules. Here we have a pre-filled syringe. You can add if you want to give something IV, you put the needle on it, or whatever. Most of the time, you don't need a needle. Our IVs are needleless. Back in the day, they were not, but they are now. This is the barrel of a pre-filled syringe. This is the pre-filled tube plunger. It goes in right there, just like that one did. Examples of medication vials here again. We have self-sealing rubber tops. So after you put either a needle in this or some type of needleless needle through here, it reseals. Pretty cool. Here is a vials. This is considered a vial. This is a glucagon vial. And this is an ampule. Ampule is designed to break right here at that blue line. And then you take a syringe with either a needleless or needle and draw up the medication. Another think about it here. Since medications can be administered by different routes, they are packaged to accommodate their intended use. So, for example, some epi is administered by injection. It's commonly supplied in a pre-filled syringe. So we can look at that. Here's epi. So it's designed this way because this is a 1 in 1,000 concentration, and it's meant to go in as an IM injection. But epi is also packaged like this, and it's packaged like that. So it's a 1 in 10,000 concentration, and we can administer an IV to someone without a pulse. So it does depend on its use. Pharmacokinetics is a branch of pharmacology concerned with the way drugs are absorbed, distributed, metabolized, and eliminated from the body. So let's look at absorption. Medication introduced to the body must first enter the body's circulatory system. And you can get to the circulatory system in different ways. Whether it could be absorbed through the skin or it could be an IV, it could be sublingual. Distribution. After medication enters the circulation, it must be distributed to target tissue on which it's intended to act. And then we have biotransformation, chemically changing medication through metabolism. So the primary organ for metabolism and biotransforming medication is the liver. Bioavailability is the amount of drug that's still active when it reaches the target tissues. How are you going to eliminate it, right? So medications are broken down into metabolites, and they're excreted from the body via different ways. Sometimes you pee it off in urine. Sometimes you breathe it off with respirations. Sometimes keep it clean. Keep it clean. Sometimes you have a bowel movement. Sometimes you might sweat it off through perspiration. And sometimes the mammary glands during lactation. Okay. Mechanism of action is the way the specific medication achieves its desired effects. Effects are the result of the medication binding with cellular receptors. I'll come back to this slide here. Bam, here you go. Here's a cell of a target tissue right here. And this happens to be a beta receptor. And there's your epi, and it interacts with that beta receptor. Just like, let me go back. Just like this could be, Narcan. Narcan's going to affect the receptors that affect narcotics on the cell, and it's going to block it. When we talk about receptor sites, specific receptor sites on cells are activated by substances that have an affinity for a particular type of a receptor, inhibit or enhance functions of that cell. That would make it like an agonist or an antagonist. Or they could have an affinity to the drug, right? It means it loves it. So either loves it or hates it. It's either going to block it or accept it. Here's a receptor site that's blocked by the medication with a greater affinity to the site. So here's your beta blocker. Right, there's your epi. It comes, but it's that epi's good. This is going to be a beta blocker. So epi is a what? It's a beta drug. Has both beta 1 and beta 2 properties. And so it's going to block it. So it has an affinity for it. So it lets it in, or it's going to block it. Just depends on what's going on. So mechanism of action. So we're talking about binding with a receptor site, changing the cell, combining with another chemical substance, or changing metabolic pathways. So if you think about it, we're talking about combining with another chemical substance. Think about aerobic and anaerobic metabolism. Like when oxygen comes into that cell, if glucose is not there, then there's a problem, right? And so oxygen binds with glucose. So that's the same with how they do these drugs. The drug is what it is until it enters the cell, and then it can change. The dose-response relationship, therapeutic threshold. The loading dose is administered to raise levels of medication in circulation to a point where the desired effect occurs. Maintaining therapeutic threshold often requires the administration of additional doses. That morphine, for example, right? I give somebody 4 milligrams of morphine, and they're like, oh, thank you. That made it feel so much better. Well, 2 hours from now, pain's coming back. 3 or 4 hours from now, pain's coming back, right? So we need to increase that threshold. And here's this is like the therapeutic threshold right here. It falls to the subtherapeutic threshold, and sometimes you can give too much, and we can actually reach a toxic level. So this right here, this is the horizontal axis is labeled in time and hours, and the vertical axis of the graph, here's your time and hours. Your vertical axis of the graph here is concentration in blood. All right. I'll let you look at that slide. It's pretty self-explanatory, though. I think it really needs explanation, but if you need questions, let me know. The dose-response relationship is going to be continued, bro. Half-life. So this is important to understand. The time between each dose determined by how long it takes for the body to metabolize 50% of the peak concentration. Therapeutic index. This is the ratio of dose of medication that's lethal in 50% of the population. The dose effective in the dose effective in 50% of the population. Okay. All right, got it. All right, so this is just factors of age, gender, body mass, and pathological state. It's pretty self-explanatory. You can read it, but basically what it's saying is age plays a role here, and it talks about like infants not having a mature organ system, or if you get to the elderly patient, age will be important because they don't metabolize stuff the same way, and they don't get rid of stuff the same way. Gender and body mass, right? So if somebody weighs, 200 pounds, and there's a big difference in 200 pounds versus 80 pounds, right? So drugs can affect that. And a pathologic state, right? Patients, when we talk about pathologic, think patients with a medical history. Like, do they have liver disease? Because if they do, the liver's main job is to metabolize these drugs. So that could be a problem if we're giving drugs like that. The same as for kidney failure, because again, earlier I just said, sometimes you pee off this stuff through your urine. If I'm not peeing as much, I'm not getting rid of waste as much, this could be a problem. And I think you get what I mean. Genetic factors, right? Thyroid hormone function problems there. That can affect how the drug reacts. The time, right? Obviously, certain drugs have shorter half-lives. Nitroglycerin's gone in 3 to 4 minutes, right? Your morphines, your hydrocodones, your pain medicines, like IV morphine usually peaks in 4 hours. So then after it peaks, it starts coming down. I would say it's probably sooner than that, probably 2 to 3. But if I give you a Lortab, well, it's going to hang out longer because it releases slower in the body. So it peaks in 4 hours and starts coming down after that. Idiosyncratic reactions, unusual reactions, the laterogenic effect, adverse effects caused by treatment provided. Tolerance, medication produces less of an effect over time. So you get, when the tolerance stuff is usually into your narcotics, like let's say I hurt myself, and they say, okay, we're going to give you these Lortab, and they're Lortab 5s, and I'm taking those, and I take them for a couple of weeks, and I'll notice in a few weeks that these aren't strong enough anymore. And so then the doctor has to increase that dose because I built a tolerance to that medication. A cross tolerance, a tolerance to medications of the same class. Same class of drug. All right. So this is habituation, an increase in tolerance following repeated dosages. That goes right perfect with the example I gave for the Lortab. The potentiation, enhancement of one medication when combined with another. So when we talk about potentiation, let's say, for instance, you have a fractured leg, and I give you some morphine. I give you 4 milligrams of morphine for that. And I'm going to say, you know what? I'm going to give you 25 milligrams of Phenergan to go with that morphine so you don't become nauseous. But it also makes that morphine stronger when I give it with Phenergan. It potentiates that drug. And so there's other things that potentiate narcotics. Take a Lortab and drink some grapefruit juice, and you can thank me later for that. Synergism, the enhancement of multiple medications when combined with one another. It's synergism. So the enhancement of multiple meds when combined with one another. Medication storage. So the DEA has strict guidelines that control how these medications are tracked, and they are very much tracked. If you get a narcotic medication like Lortab from your doctor, it goes into a database. If I go to the doctor and get that, and then I turn around and go to the ER, that ER doctor is going to know that that primary care doctor prescribed me Lortab. So they're not prescribing me a prescription as well. Medications must be stored at a controlled temperature and protected from light. Exposure to air and moisture becomes a problem for us in the pre-hospital setting, because we have drug boxes on fire trucks out there. They're sitting out there for 6 hours on a fire call, and it's 26 degrees outside. So it does affect those drugs. All right, that is it. We'll do the summary. The ability to identify medications by name and classification is important, and it's useful. It's vital to understand how different medications work and what effects they will have on your patient. You must be familiar with the various forms of medications and how they are packaged. And you need to stay current with medications your patients may be taking. All right, that is all for this chapter. I'll put the next chapter up shortly. Have a great and safe day.